My name is Trish Murphy with the Orlando Medical News, and today I'm with Dr. Murray from the Radiology Specialists of Florida, and we're going to be talking about epilepsy today. So, Dr. Murray, can you tell me, explain what exactly is epilepsy?
So epilepsy, I think first we need to talk about what is a seizure, because you can have a seizure and not have epilepsy, but if you have epilepsy, you always have a seizure.
Okay.
And a seizure is a transient disruption of brain function due to abnormal electrical activity. What epilepsy is a disease which involves recurrent and unprovoked seizures, and all of the different resultant neurobiologic, psychologic, cognitive, and social ramifications which go along with having recurrent seizures. It's a common problem. About 2.5 to 3 million patients in the United States suffer from seizures. It can affect anybody, people of all different ages, race, socioeconomic class, suffer from seizures.
Oh, wow. I didn't realize that. And I didn't understand that there really was a distinct difference between seizures and epilepsy.
Correct.
That's very good. So, Dr. Murray, when we were talking, you mentioned that approximately 2/3 of patients with epilepsy are controlled, that disease is controlled with medicine. You don't really see those folks. Tell me about the 1/3, the folks who are having issues that medicine is not controlling.
Correct. Here at Florida Hospital, we are a comprehensive epilepsy center, or level 4 epilepsy center, which is the highest level that you can be. And we are taking care of patients with intractable epilepsy or drug-resistant epilepsy. These are patients who have not responded to conventional drug therapy. They failed 2 different drug therapies. And when I mean failed a drug therapy, I don't mean they just didn't tolerate it. They had maximal optimized drug therapy on 2 different drugs, and it did not control their seizures. So when they come to us, you can imagine they are kind of wit's end and looking for answers, and hopefully that's what we can provide. Here at Florida Hospital, we have a large multidisciplinary team with many doctors, many different healthcare providers. We have epileptologists, specialized neurosurgeons, neuroradiologists, pathologists, neuropsychologists, many different PAs, ARMPs, nurse coordinators, social workers, and a whole slew of people who are involved in caring for these patients, giving them comprehensive and high-level care.
That is incredible.
It is exciting, and these patients come and they're frustrated, and hopefully often we can offer them hope.
So, Dr. Murray, say that I'm a new patient here at the center. I have epilepsy. I'm a new patient. I show up at the epileptic center. What happens?
So the first thing that'll happen is what's called a phase 1 evaluation. And what we do in a phase 1 evaluation is you come in usually on a Monday, and you stay in the hospital till Friday.
Oh, wow.
There's a battery of different studies that are done. And the main goal of those studies is to find, can we localize where your seizures are coming from? Because if we can, there's a possibility that we can treat those surgically and lead to complete seizure remission. Mm-hmm. So some of the studies that we do when you're admitted is we do video EEG. In video EEG, we have scalp electrodes on your head, so we're monitoring your electrical activity in your brain. And we're also taking a video at the same time. These patients, we also take off their anti-seizure medication when they come in because we want them to have a seizure so that we can monitor it.
Right.
And hopefully when we monitor it, they'll give us clues based on their seizure, how they're having their seizure, and their electrical activity, where the seizure is coming from. We also do many different radiology studies. We do an MRI brain. We use a 3T magnet, which is stronger and higher resolution. We can see the brain in more detail. We use specialized sequences in order to see very subtle abnormalities which potentially could lead to seizures. That's where I come in. I'm a neuroradiologist, and I read those MRIs, and what I'm looking for is a focal lesion which can explain the patient's seizures, such as a migration abnormality, mesial temporal sclerosis, or even a tumor. Other radiology studies that we do is called SPECT, which is single positron emission computed tomography. We do an intrarectal, which is with baseline, and we do an ictal SPECT. An ictal SPECT is when the patient's having their seizure, we inject a radioisotope just at that moment so we can see what's going on in the brain during that time. They'll have increased activity during the ictal portion of the SPECT that we can see on imaging. We also do PET imaging of the brain, which is positron emission tomography. Typically areas of the brain which are focal areas which are causing seizures will have decreased metabolic activity when the patient is not seizing. We also do neuropsychologic testing. Often if you have a deficit in a certain area of the brain, that can indicate, that can lead you toward that's probably where the seizure is originating. We also do, probably the newest technology that we use is called MEG, which is magnetic encephalography. And here, your brain actually produces small magnetic fields. And what MEG does is it looks at those magnetic fields. And by doing that, sometimes we can use that as another way to localize the seizure. We can also begin to map the brain with that. So one of the questions we want is not only where is the seizure coming from, but is it safe to remove that brain tissue? And what we'll do is we look at eloquent areas of the brain, such as motor function, language, memory, and sensory function. And MEG can help us map those as well. Some patients will also go on to additional studies, something called a functional MRI. And there we put the patient in the MRI scan and we have them do different tasks, like motor tasks, language tasks. And again, we're trying to map those areas and see the relationship to the possible lesion. Another study that we use is called a WADA study. And this is an interventional radiology study, where again, we're trying to lateralize what side of the patient's brain is their language and what side of the patient's brain is their memory. Is it safe to remove that mesotemporal sclerosis that's involving their temporal lobe, or will they have significant deficit post-surgery? We have to answer that question before we can go on to surgery.
Right.
Then after we gather all that, I think of it like pieces of a puzzle. And after we gather all those pieces of a puzzle, we have a seizure conference, which is weekly. All of the people gather around, there are many, many people of different disciplines, and all those studies, we go over all those studies, trying to localize a seizure focus and seeing if the studies are concordant in identifying that seizure focus.
Wow, I'm just beside myself. It's incredible the tools you guys have at your hands to diagnose and help people with their disease. So Dr. Murray, I'm the patient. I've been through my phase 1 week stay at the hospital. We've done all these tests. I go home at the end of the week. Then what happens?
So after you discuss the seizure conference, we come up with a consensus recommendation. What is the best therapy for you specifically, tailored toward you? You're brought back in, and this is discussed with you in close family. The most ideal option would be if we found a seizure focus and we can offer surgery to hopefully provide permanent seizure remission. Some patients, we can't offer that. But some patients, we can offer surgery that will decrease activity and severity of their seizures. Other patients are not surgical options. There are other options, ketogenic diet, vagal stimulator, which we'll sometimes offer as well, optimize their drug therapy. Some patients, we think we know where the seizure is, but we're not 100% sure. We need further studies to confirm the area. They'll be brought in for what's called a phase 2 evaluation. In a phase 2 evaluation, the neurosurgeon implants electrodes on the surface of the brain. These give us a more detailed picture of electrical activity during a seizure to more accurately pinpoint the focus. Some patients where we suspect a deep area in their brain is the seizure focus, we'll do what's called depth electrodes or stereo EEG. We'll use a robotic assistant to guide those electrodes into that area where we're suspicious, and we'll monitor the electrical activity of that area. If we find it and we confirm the location of the seizure, the patient will then go on during that same hospitalization to definitive therapy, which can be many different therapies. It can be laser ablation, it can be resection of the lesion, it can be subpedal resections, it can be sometimes called a disconnection surgery. So sometimes if your brain, a certain area is the focus and spreads to the rest of your brain, we can disconnect that area.
Wow.
Now, again, radiology plays an integral role in all of this. It helps with surgical planning. We also have an intraoperative MRI scanner at Florida Hospital, which the surgeon will take multiple different MRIs, both during and after the surgery, to help guide him. He'll communicate with us to make sure that we got all of the seizure focus out, or if we did a disconnection, that we completely disconnected all of those tracks so that the seizure focus is no longer connected to the brain.
Right.
Some patients will also be offered going straight to surgery if we're sure that we have a therapy without phase 2 evaluation. Often those patients get a functional hemispherectomy or a corpus callosotomy. What those are trying to do is trying to prevent spread of the seizure from one side of the brain to the other.
Okay.
So maybe we can't definitively control the seizures completely, but we can decrease their seizure activity, we can decrease the severity, we can decrease the spread from one side of the brain to the other. Again, radiology plays an integral role, as for instance in a corpus callosotomy. MRI with diffuse intensive imaging is used to make sure that we've disrupted all of those tracks which cross. The corpus callosum is the main crossing fibers in your brain. That's how your left and your right brain communicate. We try to disrupt those, and MRI confirms that those have been disrupted.
Wow, that's incredible. Sounds like you guys are really changing lives. Dr. Murray, you work with Radiology Specialists of Florida. Tell me more about that group and your role in it.
So we're a very large group. We're one of the largest groups in the country. We're very subspecialized. So for me, I'm a neuroradiologist, and I'm involved in diagnostic imaging of the brain, head, neck, and spine. There are other radiologists who do musculoskeletal radiology. We have dedicated pediatric radiologists. And really our goal is to provide the highest level of imaging and the highest level of care to the communities that we serve.
Thank you for watching, and thank you, Dr. Murray, for your time. Radiology Specialists of Florida. Quality diagnostic and imaging starts today.